So good afternoon everybody. We'll be talking about the ventilation in ARDS. So just look at the problem in ARDS. What happens in ARDS? There is a decrease in lung volume. There is an impairment of respiratory mechanics. There is a heterogeneous distribution of loss of aeration. High airway pressures are there. And with all this problem, when we try to ventilate these patients, we land up in the ventilatory induced lung injury. So as you all know, this is type of a lungs which we saw in the ARDS. What happens? There is a small area of normally aerated lung, then there is a area of poorly aerated lung, and then there is a area which is almost non-aerated, having a dense consolidation. So these type of picture you find typically in ARDS. With this concept, there was a concept of baby lung which was introduced in middle of 1980s. What they have seen in different CT scans, that the normal aerated lung in the ARDS is almost equivalent to a lung of a baby, which is a 5 to 6 year old child. So the aerated volume is equivalent to a baby's lung. That is how the baby lung concept came into the picture. And this concept provided a rationale to gentle lung treatment, because you just imagine if we are applying the same pressure, same tidal volume to a 6-year-old baby, which we are planning to do in an adult, how the lungs will behave in a baby. So that's how this gentle lung treatment was came into the picture, and there was a significant background which explains the baro and volute trauma. So the smaller of the baby lung, the greater is the potential for unsafe mechanical ventilation. So as disease progresses, this baby lung becomes smaller and smaller. So the risk of ventilator induced lung injury becomes more and more. So in this area, if I put a tidal volume, this area which is a normal area, there is the risk of over distension, and it can cause baro trauma or volute trauma. So coming back to ventilator induced lung injury is an acute lung injury that develops during mechanical ventilation, and if we have to prove, we can prove that mechanical ventilation caused this acute injury. This is not a part and parcel of the disease of the patient. It is a collateral damage suffered by the bystander healthy lung. Majority of time in secondary ARDS the lung is healthy, or even if the pneumonia is the other part of the lung is healthy, which is getting a collateral damage because of the ventilation. So collateral damage of the lung which is caught between the crossfire between mechanical ventilation and diseased lung. It could be combination of the following: barotrauma, volute trauma, atelectotrauma or biotrauma. So they all are interlinked with one another. So many times you will find the combination of these processes. The barotrauma was first recognized cause of ventilator lung injury. Excessive pressure leading to the microscopic rupture of the lung parenchyma. As you can see here, this is a normal thing, and when you apply excessive pressure, this is a collapsed lung where the surfactant has gone and this compliance has gone down. So instead this is opening up, the normal area is opening up and there is a leak. So that includes the pneumothorax, pneumomediastinum, subcutaneous emphysema. In ARMA trial, what they have said that 30 centimeter of the water is the maximum tolerable airway pressure. If you go beyond that, chances of barotrauma are high. Volute trauma, the term was coined by this gentleman, Dreyfus, may be a misnomer. Key factor causing injury is lung over distension. So volute trauma and barotrauma, they are the different aspect of the same coin, because volume and pressure are always interrelated. As you can see here, diseased lung is collapsed lung is there. So you apply the volume instead of inflating this over distends the normal alveoli. This is how it happens. So in lung, what we can do, this area which is a normal area and which is a collapsed area, we can use recruitment, de-recruitment, asymmetrical stretching with each breath. So with each breath, this area is opening up and closing. These alveoli are opening and closing, opening and closing. This dense consolidation, it is not taking participation in any ventilator gas exchange. So this is not having any problem. This area over distension, but this is a cyclical changing. So atelectrauma takes place in this zone. It is caused by the cyclical collapse and reopening of the alveoli. This name atelectrauma was given by the Arthur Slutitsky group, and Mead's model is there. This gentleman has given a model where he has said that a strain and stress and strain maldistribution throughout an inhomogeneous lung parenchyma takes place. I would like to discuss it in a further slide. This Mead's model was published in 2017 only, where they have discussed about the lung stress. So what they have said, the highest lung stress is always concentrated around the totally collapsed unit. So as you can see, this is a totally collapsed unit. Highest stress is around this, and this unit is called as a stress raisers. So the stress raisers, they increase the stress and increase the atelectasis trauma. So this is a typical ventilator-induced lung injury. Ventilation below lung volume causes atelectasis, lung inhomogeneity and atelectotrauma. Ventilation with high lung volume causes overdistension, causes air leaks. And as you can see, this is the picture. This is the atelectotrauma. This is the overdistension. Then comes another thing which is called biotrauma. In addition to mechanical form of the energy, positive pressure ventilation activates an inflammatory reaction that perpetuates the lung damage further. Ventilation leads to mechanical stress resulting in the release of inflammatory mediators from the lung tissue. And this is a biological form of trauma which is known as biotrauma, because the biological is known as a biotrauma. As you can see here, there are biological alterations, there are physiological abnormalities, and they all lead into the cascade or activating the cascade. There is a release of mediators, TNF alpha, beta carotene, interleukin 6, IL-6, IL-2B, and they cause the recruitment of pulmonary alveolar macrophages and neutrophils, and activation of endothelium takes place. So this whole thing which is a localized becomes a systemic, and this goes through the capillaries to the arterial circulation and to the target organs. So translocation of lipopolysaccharide and bacteria and various mediators takes place, and this causes the multi-organ dysfunction and ultimately lead into the death of the patient. So how to deal such patients? We have to use a protective ventilation. As you can see, this is an alveolar collapse and this is an alveolar overdistension. So here we are not producing any protection. But in a protective type of ventilation, what we are doing, we are neither allowing to have a collapse nor we are allowing to have an overdistension. So in between that safe zone, we are ventilating the patient. That is called a protective ventilation. As you all know, this is a famous acute respiratory distress syndrome trial published in 2000, where they have discussed the ventilation with lower tidal volume and compared with a traditional tidal volume for acute lung injury and acute respiratory distress syndrome patients. What they have done, they have taken two groups, which is receiving the 12 ml per kg, one is receiving 6 ml per kg. Now this is very unusual why they have selected 12 ml, but it is there, can't change it. In this the plateau pressure was more than 50, in this the plateau pressure was around 30, less than 50 and around less than 30. So what they have seen, there is a proportional of the patient, and as you can see here, there is a with lower tidal volume the survival was little better. With traditional tidal volume the survival was bad. Okay. So low tidal volume is a documented thing. We have to use low tidal volume in these patients. How much low tidal volume? Of predicted body weight. So how you calculate predicted body weight? My height is 5 feet 6 inches. What will be my predicted body weight? Any easy formula you know? So for male 5 feet you take 50 ml, 50 kg. For female you take 45 kg. And with each inch you add 2.3 kgs. Okay. So role of PEEP. So we have controlled the upper point, but the overdistension we have controlled with use of the low tidal volume. But what about the atelectasis trauma? How we can prevent the collapse? Here comes a role of PEEP. PEEP is an expiratory phenomena. PEEP keeps alveoli open at the end of exhalation. So those alveoli which were collapsing at the end of exhalation, they are kept open by using the appropriate PEEP. PEEP is a compromise between lung stretching and lung recruitment. So if you apply high PEEP, it can cause lung stretching. If you don't apply PEEP, it can cause collapse. So as you can see, if we apply the PEEP, this area becomes little big, and this area which was having cyclical collapse becomes improves, and this area which was totally collapsed becomes less. So as you can see here, we have recruited more alveoli by using the PEEP. So biggest question of life of everybody, how to select PEEP. People like Gattinoni, they have invested their whole life to identify the appropriate PEEP. So how to select the PEEP? As we all know, this is a volume pressure curve, and we all know that above this inflection point there is a over distension, below this lower inflection point there is a collapse. So we have to apply PEEP somewhere in between, that we all know. So there is, you can apply high PEEP, you can apply low PEEP. There was a trial called Express trial where they have used two sets of the PEEPs, high versus low PEEP. And what was there? Minimum distension group, low PEEP group was a total PEEP between 5 and 9. And the high PEEP increased recruitment group was having plateau pressure between 28 to 30. And one can go PEEP as high as to maintain this plateau pressure. Okay. So a strategy for setting PEEP aimed as increasing alveolar recruitment while limiting the hyperinflation did not significantly reduce mortality. However, it did not improve lung function and reduce duration of the mechanical ventilation. It did improve the lung function and reduce duration of mechanical ventilation at the duration of the organ failure. So if you are proponent of a high PEEP group, of course your mortality benefit, you will not get any mortality benefit, but of course the lung function and the duration of mechanical ventilation can be better. Then another term comes in the driving pressure. Why this? Because in PEEP again we don't know what is the appropriate PEEP. So in quest to identify appropriate PEEP, people are working further. Driving pressure is not a new concept, it is a very old concept, but it is getting popularity again. So it came back into prominence again just to identify which is the optimal PEEP. So as you can see with this graph, what is the driving pressure? Driving pressure is the difference between plateau pressure and the PEEP. So what it is mainly the elastic recoil of the lungs, elasticity of the alveoli, that is we call as a driving pressure. So if driving pressure is high, it means we have to apply more pressure to open up the lung. If driving pressure is low, it means we have to apply less pressure to open up the lungs. This trial was published in 2015 where they have said that driving pressure and the survival in the acute ARDS patients, what they have said, the influence of the tidal ventilation can be measured in better way if the tidal volume can be normalized to the compliance of the respiratory system instead of the predicted body weight. So till now we were calculating the tidal volume with the predicted body weight, but just imagine a person is hefty, big muscle mass, predicted body weight and tidal volume can change. A patient who is obese, too much fatty, predicted body weight can change. A person who is having hard bony mass, like big muscular build. So with racial variation, you can imagine different sort of the people where the predicted body weight can vary as per the height. Okay. So what they have said, to tidal volume, normalize the tidal volume as per the compliance of the respiratory system. So probably that is a better thing. This suggests that ratio of tidal volume with compliance be a surrogate to the lung dynamic strain. So as you can see in this study, what they have quoted, there is a three type of picture where they have kept the PEEP fixed and airway pressure changed. Then here they have kept the PEEP was changing with the airway pressure. But as you can see here, the driving pressure was changing. Here driving pressure was fixed. And here driving pressure again changing. And as you can see in the lower graph, this was the better thing. Okay. So higher PEEP always, not always protective. Lower PEEP, higher plateau pressure, not always risky. So with this we can see it is better. As you can see in this was the multivariate relative risk of the death in the hospital in this subgroup of the patient, and around 15 of the driving pressure, the mortality was the lowest. Here you can see they have selected 6 ml tidal volume, 6.1 ml tidal volume, and this was the 8 ml tidal volume of predicted body weight, and around 15 of the plateau pressure, it was the not plateau pressure, driving pressure, the mortality was lowest. So reduction in driving pressure was an independent variable associated with better survival. Driving pressure is currently considered the best predictor of ventilator-induced lung injury in the patient with ARDS. However, evidence behind driving pressure is at best indirect. So we don't have got a direct evidence and derived from a statistical model of the retrospective study. So whatever study I have shown is a retrospective study. This was published by the Ometo in New England Journal of the Medicine. So major drawback of rising driving pressure in isolation is that it doesn't take account into the role of PEEP. Theoretically, safe level of the driving pressure of 12 could become harmful if PEEP is 20 or 0 depending upon the clinical condition. So we don't know what is the PEEP. We are just taking the difference between PEEP and plateau pressure. So if we keep PEEP 0 and plateau pressure is certain, then if is a theoretical thing, if the driving pressure is 12, we know we are having a safe driving pressure, but we all know that in ARDS low PEEP will be harmful. So driving pressure should be referred to the lung and not to the respiratory system. This was the drawback. Driving pressure we have taken as a compliance of whole respiratory system. So what they have now postulated, the driving pressure should be taken as a lung only, not as a respiratory system. That will be more ideal thing. So now to check that comes another entity, that is a transpulmonary pressure. So transpulmonary pressure is computed as a difference between airway pressure, as you can see this is the airway pressure, and the pleural pressure. Pleural pressure is outside of the lungs between the thoracic wall in the two layers of the pleura. So it separates the pressure delivered to the lung from one acting on the chest wall and abdomen. So we separate it from pressure which is acting on the chest wall and the abdomen and the lung. Pleural pressure is measured as an esophageal pressure. So what we do, we place a esophageal catheter. As you can see here, it is inflated here and it gives a measurement. So as you can see, this is the tracing on the ventilator of the esophageal catheter. So once we get this with a calculation of this peak airway pressure and plateau pressure, if we deduct them, then we will get the true pleural pressure. So airway pressure alone may be misleading sometimes, as we see in the plateau pressure. Transpulmonary pressure offers more accurate assessment of the stress upon the lung parenchyma. Transpulmonary pressure has an advantage of separating chest wall compliance from the lung compliance, which was lacking in the plateau pressure and driving pressure both. So customization of PEEP and tidal volume setting is possible in ARDS, morbidly obese patients and with high abdominal compartment syndrome. And I would like to add one more thing in prone position as well. We are using this in prone position very effectively. And then one can detect the patient ventilator dysynchrony also by using the transpulmonary pressure. As you can see in this graph, there are two wasted efforts which are not getting triggered because of the high pressure, and with this transpulmonary pressure you can detect that there was an activity here. So transpulmonary pressure can be used to make clinical decision, which can allow PEEP to be adjusted to compensate for the chest wall mechanics. It indicates a potential stress on the lung parenchyma that can lead to ventilator-induced lung injury, and it reveals the effect of respiratory effort on the lung stress. So if you leave your patient on spontaneously breathing, then you can see if the transpulmonary pressure is going into the negative, you know that your patient is having more stress on the lungs. That could be harmful. So last slide, ARDS NET protocol. This protocol everybody should learn by heart, because this is the basic art of the ventilation. Till date, all the world, majority of the people, they follow this. You can customize it, you can personalize it with using this driving pressure or transpulmonary pressure, but basic remains the same. So inclusion criteria: acute onset of the PF ratio less than 300, corrected for the altitude, bilateral, patchy, diffused, homogeneous infiltrates consist with the pulmonary edema, no clinical evidence of the left atrial hypertension. So non-cardiogenic pulmonary edema was taken. Ventilation setup and adjustment: calculate predicted body weight, males 50 plus 2.3, height inches minus 60, so above 65 feet you will calculate. At this, female 40 5.5, you can omit this 5, you can just remember 45 plus 2.3, height plus inches minus 60. Select any mode of ventilation. So it is not that you select volume control or pressure control. Any study, there is no study which says which one is superior, which is the best mode is which you are well versed of. Set ventilator setting to achieve initial tidal volume of 8 ml per kg predicted body weight. Reduce tidal volume by 1 ml per kg at interval less than 2 hours until tidal volume is 6 ml per kg predicted body weight. Set initial rate of approximate baseline minute ventilation of the patient. So if prior to intubation patient was taking a respiratory rate of 50 or 60, if you set your ventilator on 12, you will have catastrophe. So you will have to match the tidal volume. Just imagine the minute ventilation. That time the minute ventilation could be around 12 liters, 14 liters. So you have to set the rate. Tidal volume you know, so you have to set the rate to achieve almost similar minute ventilation. Set initial rate, not more than 35 breaths per minute. Why not beyond 35? Expiratory, what is called? Dynamic hyperinflation, one thing. Another is which coefficient? Expiratory coefficient. So what will happen? The alveoli will not empty up if we increase beyond 35. Adjust tidal volume and respiratory rate to achieve pH and plateau pressure goals below. These are the goals. These are the oxygenation goals: 55 to 80 millimeter of mercury, SpO2 of 88 to 95. So don't jealously try to make it 100% or 98%. Use minimum PEEP of 5 cm. Consider use of incremental FiO2 PEEP combination. So there are two type of combination with lower PEEP, higher FiO2, and higher PEEP, lower FiO2. You can choose among them. I have already shown you the study which says there is no mortality benefit between choosing any one. So it is your choice which one you like or your hospital likes. Plateau pressure goal should be less than 30 centimeter of water. Check plateau pressure 0.5 second expiratory inspiratory pause. So in many exams, Viva, they ask how much inspiratory pause you give. In this study, they have taken 0.5 second inspiratory pause, at least 4 hourly, and each change in the PEEP or change in the tidal volume. If plateau pressure is more than 30, decrease tidal volume by 1 ml per kg in steps. Minimal you can go up to 5 ml per kg. If plateau pressure is less than 25 and tidal volume is less than 6, you can increase tidal volume by 1 ml per kg and plateau pressure more than 25 or tidal volume 6 ml per kg. So if it is less than 6, you can go up to the 6. If plateau pressure is less than 30 and breath is taking or dysynchrony is occurring, plateau pressure is, may increase the tidal volume 1 ml per kg increments to 7 to 8 ml per kg if plateau pressure remains around 30 centimeter of water. pH goal should be 7.3 to 7.45. Acidosis management, if pH is there, then one can increase the respiratory rate or maximum set rate is 35. If pH is less, then one can increase to 35. pH remains there, may increase 1 ml per kg tidal volume. pH is there. Alkalosis management, decrease ventilatory rate if possible. And for permissive hypercapnia, may give soda bicarb to correct the pH. I ratio goal, recommended that duration of inspiration be less than the duration of expiration. Weaning, conduct a spontaneous breathing trial daily when FiO2 is less than 40, PEEP is less than 8, FiO2 is less than 50 or PEEP is less than 5. So two tables, higher PEEP, less FiO2, higher FiO2, less PEEP. So they have given two different PEEP and FiO2 values of previous day. And if patient is okay, no neuromuscular blocking agent, systolic BP is okay, then you can go. Spontaneous breathing trial, if a criteria is met, subject has been in study for at least 12 hours, initiate a trial of up to 120 minutes of the spontaneous breathing trial with FiO2 less than equivalent or less than 0.5 and PEEP 5. On TPs, just look at, assess the balance of, assess the tolerance as below up to 2 hours. Look at the SpO2, PO2, spontaneous tidal volume, respiratory rate, pH, no respiratory distress. If tolerated for at least 30 minutes, consider extubation. If not tolerated, resume the pre-trial settings. So the use of small tidal volume, low driving pressure and low plateau pressure in ARDS is supported by the physiological data and controlled trial. So these three are supported by the data and trial. The use of PEEP to minimize cyclical derecruitment, atelectrauma, inhomogeneity and stress razors has a strong biological rationale. Controversy remains with respect to the titration of tidal volume and PEEP, and measurement of driving pressure, pleural transpulmonary pressure or strain allows individualized tidal volume prescription to minimize the risk of ventilator induced lung injury. Thank you very much.